One. We are live now.
Good morning, good afternoon, and good evening. I am Dr. Ajay Shetty, the Educational Chair of the APSS, and on behalf of APSS, I welcome you all for joining the APSS second Advanced Spine webinar on Endoscopic. My special warm welcome to the President of APSS, Professor Dato Kwan, the moderators of this session, Dr. Vijay Kumar Loya and Dr. Wu Pang from Singapore, the faculty members, Dr. Zhang Wei, Dr. Pramod Lokhande, Dr. Kim and Dr. Wu, and the case presenters, Dr. Bing from China and Dr. Yudha Sakti from Indonesia. I would like to invite Professor Kwan to deliver the presidential talk. I invite Professor Kwan, please.
Yeah, thanks, Ajoy. Yeah, thank you, Ajoy. Yeah, hi to everyone. Welcome again to our APSS webinar entitled Endoscopy Spine Surgery. So the APSS as well as the APSS leadership are very honored and happy to organize this our webinars education event for all our APSS members as well as non-member, especially around this Asia Pacific region. And we are happy to have all of you here. So this year, we have many webinars, and this is a second advanced spine webinars to address the very hot topic, which is endoscopy spine surgery. I would like to sincerely thank the educational committee led by Vishal and the team under the leadership of Dr. Ajoy, which have actually continued design this type of webinar program that will benefit all of us here. So for today, endoscopy spine surgery, we are very happy to be able to invite 4 prominent speakers. Professor Woo Kim from Korea, Professor Pramod Lokhande from India, Professor Zhang Wei from China, and my good friend Wu Pang from Singapore. Thank you, all right, for joining this session and enlighten us and also teach us, all right, with the latest advancement in this topic. So I would like to take this opportunity to thank Kaylin and Jennifer from the Secretary, as well as OrthoTV for making this event as possible. And lastly, thanks to all of you, the participants. Thank you for joining us. Back to you, Ajoy.
Thank you, Professor Kwan. I think we already highlighted the program overview. As you are aware that this is the seminar would be on endoscopic spine surgery. We have an excellent scientific speakers, Professor Quinn, who is going to speak on transforminal endoscopic lumbar decompression and discectomy. Dr. Pramod Lokhande, who is going to speak on Uniportal interlaminar endoscopic decompression and discectomy. Dr. Zhang Wei from China, who is going to speak on biportal endoscopic decompression and discectomy. And Dr. Wu Pang, who is going to, who will be other speaker, who is going to speak on both uni and biportal endoscopic lumbar interbody fusion. We also will have case presentation by Dr. Yudha Sakti and Dr. Xu Wei Bing on the use of endoscopic procedures in various spine pathologies. I would like to invite and hand over the proceedings to the moderators of this section, Dr. Vijay Kumar Loya and Dr. Pang Wu.
Thank you, Professor Joy and Professor Kwan for gracing our occasion. I'm Pang Hong Wu. I'm from Singapore. It gives me a great honor to welcome our first speaker, Professor Woo Kim. He's also my mentor in Uniportal endoscopic spine surgery. He has now recently he become the president and opened his Harrison Spinatus Hospital Cheongdam in South Korea. He's now going to present to us transforminal endoscopic lumbar decompression and discectomy.
Thank you so much, Dr. Wu. It is my great pleasure to give a talk at the APSS webinar. Today, my lecture topic is transforminal approach for lumbar disc and sternus pathology. Dr. Jennifer, can you play the video?
Hello. Thank you, Chairman, for the introduction. I'm Hyun Kim from Harrison Spine Arthros Hospital, Cheongdam of Spinal Endoscopy Center. I'm delighted to be able to talk about the APSS second advanced webinar program, endoscopic spine surgery. Today's my topic. I will be lecturing today is transforminal endoscopic lumbar decompression and discectomy. The rationale of full endoscopic spinal surgery is to preserve the segmental function structure as much as possible while effectively removing the pathology point. As in this case, transforminal access is the most effective way to accomplish this purpose of full endoscopic spinal surgery. Surgeons who perform endoscopic spine surgery should always consider this purpose based on performing spinal surgery. For the development of endoscopic spinal surgery, the development of endoscopic instruments was essential. In addition to the endoscope of the existing small diameter working channel, a larger diameter working channel has been developed to facilitate decompression and fusion. Advances in radiofrequency ablation system for soft tissue manipulation and the endoscope dual system for hard tissue manipulation were entailed. Currently, the full endoscopy approach performed for lumbar degenerative spinal disease is: first, there is ipsilateral transforminal endoscopic lumbar discectomy for disc pathology, and second, ipsilateral transforminal endoscopic lumbar foraminotomy (TLF), and third, ipsilateral paraspinal endoscopic foraminotomy (TLF) for foraminal stenosis, and finally, uniportal full endoscopic transforminal lumbar interval fusion can be added. First, let's look at transforminal discectomy. Transforminal access using a small scope has become more mobile and more easily accessible to the target point, along with the development of surgical techniques and endoscopic instruments. As a representative transforminal access for highly inferior migrated HMP, the Scott suprapedicular circumferential opening technique, which removes the upper part of the pedicle and performs an angled approach introduced by me, and the second, additionally, a transpedicular approach introduced by Kuntram, in which a part of the pedicle midsection is removed by the drilling. Representative transforminal access to highly superior migrated HMP can be divided into transforminal access that goes up the lower part of the upper vertebral body, and posterolateral approach that access after removing part of the lateral part of the pars. Now let's look at the cases. This case of highly inferior migrated discus, the transforminal approach was not easy before, but now is easily solved through various approaches, including the Scott suprapedicular circumferential opening technique introduced by me. In particular, in recurrent HMP, which is not easy for revision open surgery, but the transforminal endoscopic approach is a good way to effectively resolve the symptomatic pathology while almost completely preserving the functional segment in the cases of recurrent HMP after open lumbar discectomy. For more highly inferior migrated or superior migrated cases, The transforaminal approach is not easy due to bony obstacle of pedicle, but now it is more easily solved through in various approaches, including the transpedicular approach introduced by the Kundani. Foraminal to superior mobility discs are often difficult to approach in open surgery. However, in transforaminal endoscopic lumbar discectomy, if the foraminal root and the vertebral riding technique is used, damage to surrounding tissue can be minimized with effectively solving this problem. In spite of the case of highly superior migrated discs combined with spinal stenosis, if sufficient drilling of the superior articular process is possible, a more effective and safe access route can be secured. High lumbar level HMP can be cause nerve damage in open surgery, so it is not easy to remove the region effectively in the open surgery. However, in the transforaminal endoscopic lumbar discectomy, it can minimize this problem and take an excellent result without serious complications like these cases. According to recent study by me, even in impending neurology such as this case, the transforaminal endoscopic approach can more minimize neural retraction, thus more minimizing nerve damage and more effectively resolving lesions compared to open surgery. Transforaminal access can also be used effectively in thoracic regions. This figure introduced by Dr. Mathan, and as explained in these figures, effective and safe access to the thoracic region can be achieved by using sufficient foraminotomy. Upper thoracic transforaminal access has already been discussed by Dr. Bei, introduced neurospine, and the disc regions can be effectively removed using transforaminal access in spite of the higher thoracic level. In particular, in thoracic regions, the disc is often located centrally, which makes transforaminal access difficult. In this case, if sufficient foraminal space is secured using a drill, even a central disc that is difficult to access can be effectively removed by the Uniportal full endoscopic transforaminal approach. Next, let's look at foraminal decompression, foraminal stenosis. There are 4 Uniportal full endoscopy approaches for foraminal stenosis. First, transforaminal decompression. Second, paraspinal decompression. Third, contralateral interlaminar decompression. And fourth, full endoscopic transforaminal lumbar interbody fusion. Here, let's talk about the transforaminal approach and the paraspinal approach of 2. Structures related to foraminal pathology, not only the disc, but also the thickened ligament flavum and osteophytic component are complexly involved. A simple resolution of discs and the thickened ligament flavum often does not effectively resolve symptoms. Therefore, good results can be obtained when disc, SAP, superior articular process, osteophytic bone, and foraminal ligament, which are related to foraminal stenosis, are effectively removed. Also, whether or not the instability is increased due to decompression should always be considered. The concept of transforaminal access to foraminal stenosis is a partial resection of SAP using a less angled approach. Therefore, in some patients corresponding to the indication, the maximum effect can be obtained with the minimized option. In particular, in the case of stable foraminal stenosis in which lateral recess stenosis is not prominent, effective result can be obtained with only partial resection of SAP using transforaminal access. This patient is a 67-year-old female patient with foraminal stenosis as the main disc pathology. Although the lateral wedging instability is not severe and the instability is not prominent, in this case, effective result can be obtained with SAP partial resection and disc preparation using a transforaminal approach. However, if degenerative osteophytic changes are accompanied in addition to the disc pathology and the lateral wedging instability or instability is severe, as in this patient, there is a high possibility of recur with simply a partial resection of SAP decompression. This patient was a patient who eventually underwent fusion as a recur of foraminal stenosis. Rather, it is considered reasonable to select the method of SAP total resection, decompression, or fusion as the first operation for this patient. Now, let's learn about the full endoscopic SAP total resection paraspinal foraminal decompression. Full endoscopic SAP total resection paraspinal foraminal decompression has already been introduced by Dr. Lee. It aims at SAP total resection and complete foraminal decompression and aims to reduce facet joint damage as much as possible. Therefore, as shown in this figure, part of the lateral part of the pars is removed and SAP total resection is aimed. But the goal is to minimize damage to the articular capsular ligament and the facet. For example, in the case of a 66-year-old male patient with a very highly superior migrated rupture disc at L45, the partial SAP resection transforaminal approach may be sufficient to remove the rupture disc. However, in this case, it is not easy to remove the final point of a highly superior migrated disc using transforaminal uniportal full endoscopic approach. Rather, if a full endoscopic total SAP resection foraminal decompression is used, even highly superior migrated lesion can be effectively removed. As seen in this patient, a 57-year-old woman, full endoscopic SAP total resection foraminal decompression seems to damage the facet joint a lot. But in fact, as a result of a post-operative 3D CT examination, the facet joint is almost perfectly saved. It has no significant effect on the progress of instability. The final method of the full endoscopic approach for foraminal pathology is full endoscopic transforaminal lumbar interval fusion. For details, Dr. Wu will introduce, so I'll give you a brief introduction to the overview. The currently implemented endoscopic transforaminal lumbar interval fusion is divided into transforaminal Cambin's approach and the posterolateral approach. Among these, the transcambin approach is a method using a foraminal root. In fact, the posterolateral approach can also be considered as a technique aimed to a foraminal decompression if Kim's point starting from the lateral part of the facet joint is used. In conclusion, endoscopic spinal surgery is currently taking its place as the mainstream of spinal surgery and treatment. However, we must always remember the origin intention pursued by endoscopic spine surgery. Transforaminal access has the ultimate goal that endoscopic spinal surgery pursues, and through this, the development of spinal endoscopic spinal surgery should be pursued. Thank you for your kind attention.
Thank you, Prof. Hyeun Kim. I think let's see whether we have any questions from the floor.
So there are no further questions. If there are no further questions, we can move to the next talk by Dr. Pramod Lokhande. He's going to be speaking about interlaminar full endoscopic discectomy and decompression. Dr. Lokhande.
Yeah, good afternoon, friends. Greetings from Pune. So I'm Dr. Lokhande. We'll be talking on full endoscopic interlaminar approach, which covers lumbar discectomies and decompressions. So my main focus would be to cover discectomy procedure, and if time permits, I'll talk a little bit on stenosis decompression. So all of us know that the primary focus of modern spine surgery is to minimize access-related injury and to avoid unnecessary fusions. And both these objectives can be achieved very well with full endoscopic procedures, because the reason for that is it is a target-specific approach. It actually utilizes the least possible, the multiple approaches possible, so that minimal damage is done to the soft tissues and the bone to access the herniation depending on the location of the herniation. Out of the multiple approaches possible, I think the two most important or the classic approaches are the interlaminar approach and the transforaminal approach. So these are the two basic approaches, and both of these go hand in hand. None of them, it stands alone. Either of the approach is incomplete without the other one. These are like right and left hands for each person. So of all the indications which I know about, I think 30% of my procedures are by transforaminal, and nearly 70% of the procedures are done by interlaminar approach because of the versatility of the approach. And if you look at the axis of transforaminal approach, it is to the intervertebral foramen. So the best indication or the ideal indication for that is the foraminal and the extraforaminal herniation. And since it utilizes the intervertebral foramen, the larger the size of the foramen, it is easier for us to access the herniation. And as you go downwards, the size of the foramen becomes very narrow, and especially in elderly patients where because of hypertrophied or arthritic facets, it might be very difficult for us to access the spinal canal without cutting the facet joint. So these are the indications for transforaminal approach. So these are the limitations. The undersurface of the facet is the main barrier which prevents access to migrated disc herniations, and the upper part of the pedicle also. So a lot of times we have to drill this particular area to visualize the down migrated herniation so that it can be easily removed. Another important limitation is the position of the iliac crest. If it is very high, it's very difficult for you to reach the center of the spinal canal. You will be able to reach a paracentral herniation which is down migrated, but for an up migrated disc herniation, it's very difficult for us to access it, especially it is very sequestered. Secondly, we need to also consider the possibilities of transitional zone anomalies where there is a fusion between the ala and the transverse process of the L5 vertebra, which will prevent direct access into the spinal canal. So another thing which I feel that whenever a transformal approach is contemplated, that you should look at the sagittal sections of the MRI and look at the location of the exiting nerve root. Sometimes it can be lying at the level of the disc. So the vertical height of the Cambian's triangle is reduced, and in such cases, the exiting nerve root directly comes in line with the trajectory of the endoscope, and it may get damaged. So these are the possibilities that you have to be aware of, and you should try to avoid this particular approach in such patients. Interlaminar transformal approach, I think, as we discussed before, is very good for the upper lumbar spine, whereas interlaminar approach is mainly indicated for the L3, L3, 4, L4, 5, and L5S1. So it caters all types of intracanal herniations, whether they are central, paramedian, migrated, calcified, ossified. If they are associated with stenosis, you can easily deal with it. And as discussed before, L5S1 intracanal herniation, where transformal endoscopy is not possible. So these are the indications of interlaminar endoscopy. The procedure is very simple, and it begins with the docking of the working channel. Here you have to take a 8 millimeter incision in the center of the interlaminar space. A dilator is inserted till it reaches the facet joint over which the working channel is inserted. And this completes the docking of the working channel. Hardly 4 shoots are necessary for this procedure. And once the endoscope is inserted, you have to be aware of 2 conditions. Look at the size of the interlaminar space. There are 2 possibilities: a wide interlaminar space and a narrow interlaminar space. A wide interlaminar space is the, in this particular thing, the facet doesn't cover the traversing nerve root. The traversing nerve root lies away from the facet. And in such cases, it is not necessary for you to do any bony resection. You just make a small slit in the interlaminar window over the ligamentum flavum, and you can access the herniation very easily. Whereas sometimes if it is a narrow interlaminar space, here the traversing nerve root usually lies hidden under the facet. So the medial part of the facet needs to be drilled to uncover the lateral border of the nerve root so that access to the herniation can be easily gained. So let's start with the first scenario, a wide interlaminar space, very large. Usually this wide interlaminar space is seen in L5S1 level. Very large axillary disc herniation on the right side. And once the endoscope is inserted, some muscle fibers are removed to expose the ligamentum flavum. So this is the exposed ligamentum flavum. You start cutting it layer by layer under high magnification. The cannula is used to retract the slit. Because the flavum is elastic, it's very much easy for you to retract and make the slit bigger. So you continue cutting the flavum till the lateral margin of the facet, and this is the lateral margin of the nerve root. Since it's an axillary disc herniation, you don't retract the nerve root medially. You have to go in the axilla of the nerve root directly. This is a wide open axilla because of the herniated fragment, and there you see the hernia popping out, and multiple fragments are removed. This is a hernia which is completely removed and the nerve root well decompressed. If you look at the final slit, the diameter of that particular slit is hardly around 2.5 millimeters, and the length may be around 1 centimeter in size. So this is the herniated fragment which was being removed. These are the post-operative MRI pictures. Another case, a narrow interlaminar space where the traversing nerve root is covered under the facet joint. And in such case, we have to do the medial facetectomy of the facet joint just to widen the interlaminar space. So this is an up-migrated disc on the right side with a discal cyst. And what I've done after the flavum is, after the exposure is done, you start drilling the medial margin of the facet just to widen the interlaminar space so that the lateral border of the nerve root can be uncovered. So this is the nerve root, hemostasis is achieved, and you angle the endoscope and the working channel to locate the discal cyst. That's the discal cyst. Once an incision is taken on top of the discal cyst, then multiple fragments can be removed, And this is the final picture of the decompression. That's the well decompressed traversing nerve root. These are the post-operative MRI pictures of the same patient. 8 millimeter incision, and we usually don't keep any drain inside. Another case of L4-5 up-migrated disc herniation on the right side. Here, I've rotated the cannula to retract the nerve root, and these are the fragments which I'm removing. That's the PLL which is being cut. You see the 25 degrees angled endoscope allows you to look under the nerve root and the dural sac to visualize the ventral epidural space. So that's the ventral epidural space there, and that's the nerve root. All the fragments being removed completely under direct vision. Now, sometimes we get a strange case like this. This is a foraminal disc herniation on the right side at L5S1 level. Now, transformal approach in such cases is difficult because of the presence of the iliac phase. So either we can go trans-iliac or we can use this contralateral interlaminar approach. And personally, I feel this contralateral interlaminar approach is a more minimally invasive and more safe technique compared to trans-iliac approach. So this is the approach what we use. We go from the normal side towards the opposite side facet. We drill in the midline at the spinolaminar junction, remove the flavum on the opposite side. This is the drilling of the contralateral facet joint. That's the exiting nerve root. That's the exiting nerve root. And that's the foramen. You cut open the annulus, release the fragment, and large fragments can be removed through that particular area. And that's the osteophyte which is there on the margin. And this is the exiting nerve root, well decompressed. That's the traversing nerve root. This is the dural sac. And you see that the ipsilateral ligamentum flavum is kept intact. So that's the beauty of this procedure, that it's more minimally invasive as compared to the other procedures. What about revision interlaminar approach? Yes, it's possible. And personally, I feel that revision surgeries are more easy and safe with an endoscope as compared to open surgery. And this is one case, post microdiscectomy procedure, 2 years, patient has got severe left L5 radiculopathy with lateral recess stenosis and a disc herniation. And the procedure slightly changes here. We have to, because of the scar, we do a sharp dissection under C-arm. We insert a stab knife directly under C-arm to up to the level of the facet joint. And once you insert the dilator should be directed towards the bone, that is the facet joint. So it doesn't penetrate through the dural sac. And that's the final docking of the working channel. Once you dock yourself on the facet, you release the scar tissue from the medial margin of the facet joint. This is the scar tissue being released. Drill a little bit of bone to create some space for your instrument to go in. This is the medial margin of the SAP. The scar has been detached from the medial margin of the SAP, and you remove the medial margin with the help of a Carrison punch. This is a nerve root which is well adhered to the underlying structures. You retract it. There's an osteophyte there along with the disc herniation, and that's the disc hernia being removed. And this is the osteophyte. We drill it with the help of a hand drill. It's called as a face mill, and that's the well decompressed final picture of the nerve root. So these are the limitations. I think it's impossible for us to access the extraforaminal or foraminal disc herniation unless you use a contralateral approach. So that's not a real indication for interlaminar approach. Upper lumbar levels, again, we face the same kind of problem which we face with open lumbar discectomy at the upper level. Because of the size of the neural structures is much big, and the size of the facet is the more amount of facet joint has to be resected. So it is particularly not advisable for you to do an interlaminar approach if a transformal approach is possible at that particular level. And sometimes in a broad-based disc herniation, you may have to do a bilateral interlaminar approach. You can use the same skin incision but different facial incisions to remove the complete hernia when there are patients with bilateral nerve root compression. So coming to the second part of the lumbar talk, which is the lumbar canal stenosis. There are different techniques. I mean, some people, they use the translaminar technique. Others, they start drilling at the tip of the SCP. So I particularly feel it depends on the area where you're decompressing. Like majority of the lumbar canal stenosis patients, they're seen in the lower lumbar spine. So where a rectangular kind of laminectomy or laminotomy useful and it's possible. So in that case, I usually prefer to start drilling at the tip of the descending facet or tip of the inferior articular process of the superior vertebra, and you start drilling along the medial margin, go towards the superior lamina, drill towards the superior lamina. Whereas at the upper lumbar levels, what happens, you can't drill too much of the facet joint because if you drill too laterally here, the pars will break. So to save the facet joint, the laminotomy or the laminectomy at upper levels has to be in a triangular fashion to save the facet. So to save this, I try to start my drilling at the base of the spinous process, which is the base, which is the spinous process and the laminar junction, the spinolaminar junction. So majority of the drilling is done here, and then in the late stages you come on the medial margin to decompress the nerve root. So this is the first technique which I was talking about to expose the tip of the descending facet. Here the soft tissues are removed from the attachment of the medial margin of the facet, and that's the tip. So this is the exposed tip. I usually start drilling there, go along the medial margin towards the superior lamina, and then come to the inferior lamina. So this is how we do. We do it with oval burr with a side protection, and drilling is, we do it with the oval burr with a side protection. And drilling is continued in two ways. Either it is continued till the attachment of the ligamentum flavum is separated from the superior lamina, or you see the tip of the ascending facet or the tip of the SAP. So these are two different ways in which you can start drilling. So that's the tip of the SAP. Can you see that? And once that is done, you start drilling the medial margin of the SAP or the ascending facet. So this completes the widening of the interlaminar window. So once the bony resection is done, then you start removing the ligamentum flavum. Initially, you can do it with this way, or you can do an en-bloc resection. So aim is to do a complete flavectomy from all sides. The thinned out lamina is removed with a Kerrison punch. And once the ipsilateral decompression is completed, you tilt the endoscope on the opposite side under the lamina over the dural sac, and contralateral decompression starts. This is the drilling of the medial margin of the contralateral facet. The aim is to uncover the opposite traversing nerve root till the lateral border is well seen and can be accessed well. That's the axilla of the opposite nerve root, and this is the ipsilateral nerve root, all well decompressed. So what is the subcordocranial extent of decompression? You start from the tip of the SAP to the middle of the pedicle. That is the Siam guided kind of thing, but majority of the times you don't need to once you get experience about how much to drill. So this is again a video of contralateral decompression. This is the drilling of the medial margin of the contralateral facet joint. Aim is to thin it out with a burr. Then the thinned out remaining lamina is then removed with a tube sheath punch or a Kerrison punch. That's the contralateral nerve root. The lateral border is well seen. That's the lateral border. And this is the dural sac and the ipsilateral nerve root. So we usually don't keep any drain inside, and the patient is mobilized immediately in the same evening. This is again a very tight stenosis, partially drilled superior lamina. Here we have attempted to do a complete flavectomy. This is one of my initial cases done in 2018 or 19. This is removal of the inferior attachment of the ligamentum flavum midline to reach the opposite side. Then you just, with the help of a dural dissector, you separate the ligamentum flavum from the undersurface of the dural sac and remove it as a single piece. This is the contralateral ligamentum flavum. You drill the facet joint, keeping the contralateral flavum intact, and this is separation from the lamina. The overhang of the medial margin of the facet is then removed to decompress the opposite. So that's the opposite contralateral nerve root, traversing nerve root, and this is the contralateral exiting nerve root of the opposite side. So three nerves can be decompressed at the same time. So these are the pre-operative and the post-operative MRI pictures. We are able to do multi-level decompressions also, again, like up to 5 level I've done, and with very good results. So is it possible for us to do multiple levels in a single incision? Yes, it is possible. Now, this is one of those cases where I've done it through a single level, and you can see the endoscope being tilted intraoperatively just to reach the opposite side. So it is possible for us to do 3-level decompression with a single 8 or 10 millimeter incision. This is the intraoperative pictures of the same patient. And to summarize, I think interlaminar approach is a very versatile approach. It has ability to deal with variety of indications, right from disc herniation, stenosis, tumors, infections, so many indications are there. Most importantly, I feel it is very, very well accepted by beginners because it's so familiar to them as it is so close to the conventional microdiscectomy procedure, very less fluoroscopy exposure. And it is the mainstay approach, I feel, in the lumbar spine and the cervical spine. Thank you very much.
Thank you, Dr. Pramod, for your comprehensive talk. There's a question in the chat for you. Can you use interlaminar approach for foraminal or extraforaminal disc or stenosis?
See, I have demonstrated one case of interlaminar approach to decompress, to remove a foraminal disc herniation. Yes, it is possible, but I wouldn't advise it as a regular procedure. It is done in some special cases where a conventional easy approach is not possible. So personally, I feel that if you are well versed with a transformal approach, it's a much more easy approach to deal with foraminal and extraforaminal pathologies.
I have a question where I think a very excellent presentation. Sometimes there's a double root anatomy variation especially in the L5 and S1 level.
Yes.
Because in the interlaminar there is a hole in the flap ligament. So I think the view is a limitation. How to prevent another no root injury?
Yeah. So for this, what we do, yeah. So for this, what we do is we follow the conventional principles of open surgery. That is, you have to reach up to the medial margin of the pedicle. So that's where you know that there is no lateral nerve root lateral to that particular. So medial margin of the pedicle is something which we palpate. So aim is to always visualize or palpate that, and then you start retracting the nerve root. So unless you do that, I think it's quite possible that you may injure one of the nerve root, considering it is as disc herniation. And this is very common, especially in the cervical spine, because we instead of rather than in the lumbar spine, my particular experience is I've seen more congenital nerve root anomalies in the cervical spine as compared to the lumbar spine, and there one root is sitting on top of the other. There are separate motor and sensory components. So unless you are very, very aware, so pedicle is the most consistent bony landmark, which I feel to identify these particular anomalies. And if you palpate that and start from that lateral and go towards the medial side, it's easy for you to avoid these kind of problems.
There's another question.
Okay.
Yeah.
I think there's one question for Prof. Kim. So he's online. So we asked him first from Chikit. Prof. Kim, would for obese patient, would endoscopic surgery be advantage or not compared to open surgery? What would be the challenges? Yes.
Yeah, but you ask about the obese patient, maybe.
Obese patient, yes.
Yeah, actually, endoscopic spine surgery more benefit in the endoscopic spine surgery compared to the open surgery, because maybe endoscopic spine surgery really can access to the target point more easily. In spite of the very obese patient, the access is not difficult in the endoscopic procedures.
Okay.
Yep.
So I think for the revision endoscopic surgery, Chikit asked to Dr. Pramod, can you do revision surgery for recurrent prolapse disc?
Yes, of course. I showed one of the patient, one of the cases where we have done revision interlaminar approach after open microdiscectomy. Actually, I've had experiences. I've done a 4th approach with an endoscope after previous 3 open microdiscectomy surgeries in the same patient, same level, same site. So I feel that doing a endoscopic procedure is much more easy as compared to a revision interlaminar procedure, because first of all, the visualization is so excellent. You are able to identify each and every fiber of the facet joint capsule and the scar tissues and all those things. So the chances of neural injury are very, very rare. But I think for you, a beginner, it's not a case for a beginner surgeon. I think you need a considerable experience handling of the instruments, handling the tissues, understanding of the anatomy to start with a revision interlaminar approach. It is more of a advanced surgeon's case rather than a beginner's case.
I think the next question can go to both Prof. Kim and Prof. Pramod, also from GK. For foraminal and extraforaminal stenosis and prolapses, for L5S1, can we do interlaminar approach or transforminal approach? And I add one more sub-question to that. Would you prefer to use the big scope or the small scope, transforminal scope on the stenosis scope?
Okay, can I give a talk?
Yes.
Actually, L5S1 foraminal is very, very difficult, maybe. But in the endoscope procedure, it's more benefit. There have so many advantages. We also can use some large scope and sometimes small scope. Using the large scope, we can possibly to paraspinal approach, and using the small scope, we can possibly go to the contralateral interlaminar approach. But actually in L5S, foraminal approach is sometimes not easy, and the result is not good because of it. Maybe if you try some L5S, maybe I recommend some large paraspinal or some contralateral interlaminar approach. That will be more good.
Yeah, I agree with Professor Kim. I think, but one more thing, like if you're planning to do a transformal approach with a larger endoscope, I don't think the inside-out technique is the feasible one, because the size of the endoscope is going to irritate the exiting nerve root. So it's too dangerous for to try out a interlaminar inside-out, transformal inside-out technique with a large scope. If you really want to do it, then I would suggest you land on the facet, drill the facet, and keep the scope floating over the exiting nerve root so that you can deal with a transformal pathology with a larger scope. But as Professor Kim said, that for an interlaminar approach at contralateral interlaminar approach at L5S1 is the better way to deal with foraminal pathologies as compared to a transformal approach. Yeah.
Okay, then I think that's a final question now from Prof. Kwan. What is the learning number of cases required for beginner? I think for transforminal as well, then and separately interlaminar. Before we go on to the next segment.
Yeah, Professor Kim, are you taking or should I talk? So what I feel is that I think it all depends on the training and how well structured training program you have undergone. Like, have you attended all the lectures? Have you done observership? Have you actually done some hands-on work on the cadavers? So if you do all that and if you stick to the basic principles, I think around 20 to 25 cases are enough for each technique for you to be comfortable with. But if you're going in random, then I think even if you have done 100 cases, it's not worth, you will keep making the same mistakes again and again.
Yes, I do believe so. I think people who are encouraged to do endoscopy should frequently attend meetings and get updated of the techniques and really get interested in reading how endoscopy can resolve problem. I think the indications are very important. More of sometimes as important as execution of the technique. Thank you, Prof. Pramod and Prof. Kim, for your expert opinion. We'll move on with the program on Biportal. So it's my pleasure to introduce Professor Zhang Wei from China. He's the Deputy Chief Orthopedic Physician, for one of the founding members of the International UBE in China. He's practicing currently as a deputy chief orthopedic physician in Hangzhou traditional Chinese medicine hospital. His topic is on bipolar endoscopic decompression and discectomy.
Hello, everyone. I'm Dr. Zhang Wei from Hangzhou Traditional Chinese Medicine Hospital. It's my honor to join the webinar. Thank you for Professor Wu Penghuang's invitation. Today's my topic is UBE decompression and discectomy. This is a basic technique for the UBE. For example, the L4-5 disc herniation. The two pictures shows the location of the portals. First, we draw a red line, horizontal line in the level of the junction of the spinal process and the lower margin of the laminar, and draw a vertical line is median margin of the pedicle. The cross point above 1.5 centimeter is Biportal. Below 1.5 centimeter is work portal. First, we will clear the soft tissue on the floor anatomy. This laminar swelling process, the lower laminar, the IP. I use the radio frequency to clear the soft tissue on the surface of the floor anatomy. Then I use a burr to make thin the laminar and the median margin of the IP. Then I use a carry-thin punch to remove the low margin of the laminar until I found the proximal insertion of the flav ligament. Too much bleeding in this area because there's small vessel on the surface of the dura. I use the small size radio frequency to do the bleeding control. Then I make thin the median margin of the IP. I use the curved osteotomy to remove the median margin of the osteotomy of the IP. Then this is the corner area is very important anatomy. Under the corner area is a nerve root. Corner is formed by the upper margin of the laminar and the median margin of the SAP. I use piercing punch to remove the bone, and the distal insertion of the flav ligament will be found. Until I found the median margin of the pedicle, I will find the nerve root. According to the median margin of the pedicle, we remove the median margin of the SAP. I will release the proximal distal insertion of the flav ligament, and also I release the median line of and the lateral margin of the flav ligament. Then I remove the flav ligament totally unblock removement. Then I retract the nerve root. I will find the disc herniation, and on the surface of the disc herniation there are too much the vessels. So I will first do the bleeding control. Then I will perform the discectomy procedure. After this procedure, I will use a small radio frequency or bigger radio frequency to shrink the feeder. Maybe I will do the annular fibrous suture repair. At the last, we will insert the drainage. This is a video shows the left side approach of the L45. First, I will clear the soft tissue and using the diamond bone to mix in the laminar and remove the laminar by the current punch. You can see the proximal insertion of the flare ligament. This is the tip of the IP, and we will find the corner ligament. Then I use the bird to mix in the medial margin of IP. Make a scene, it will be easier to use the curved osteotomy to remove the part of this part. And this part is surface of the SAP. So we will, this is the corner area. You can see the upper margin of the laminar and the medial margin of the SB. I use Pearson punch to remove the bone, and we will find the distal insertion of the flare ligament. Then I will release the midline of the flare ligament. This is the basement of the L5 spinal process. From this, from here, I will release the midline of the flare ligament. This area is we must pay attention to this area. It's often the dural damage. We often happy here. This is a 3 millimeter calcium punch. Release the midline of the flare ligament. I use a 30-degree endoscopy, and you also can choose the 0 degree. I use a curved calcium punch to release the lateral part of the flare ligament from the proximal to the distal. Then I can remove the flare ligament totally and block removement. This is the UB retractor. We found the disc coronation, the too much vessel, plus small vessel, and fibrous tissue. I use the small size radio frequency to release, to do bleeding control and release the fibrous tissue. I use these tools for insert the P-valve safely. It's similar to the detector. I can insert the key valve as a retractor. So my assistant will be feel happy. He cannot hold the retractor. Discectomy is similar to the open procedure. I will use the flash as the fragment outside. Then I use at last I use a small size to shrink inside of the disk space. I use the big size radio frequency on the surface of the annular fibrous to shrink the annular fibrous. So the decompression is full. I use the bone wax to do the bleeding control on the bone. Then I insert the drainage. So we finished our discectomy. Thank you for your attention.
Thank you, Professor
Thank you,
Zhang,
Doctor.
for the wonderful talk. Yeah. Loya, you can take it if I'm away. Yeah.
Yeah, I don't see any questions in the chat. So any of the panelists, if they want to ask a question to Dr. Zhang.
I think we can go to the next segment.
Yeah,
After I
if
finish
no-
mine, then there will be
Yeah.
more questions, I think.
Yeah, so we can move forward to the next talk. That is uniportal or biportal endoscopic fusion by Dr. Wu Pang. Dr. Wu.
Yeah, okay. Greetings, everyone. I'm Dr. Pang Hong Wu. Thank you, APSS, second advanced spine webinar, for the invitation for coming to speak about this topic. Thank you, Professor Kwan and Dr. Vishal, as well as other eminent speakers, for coming to this occasion of webinar to share their expert knowledge. Today, my topic is uniportal and biportal endoscopic fusion. I've been trained in several countries for fellowship to understand both the open endoscopic surgery, and currently I'm a senior consultant in a Chief Spine Orthopedic Center, Mount Elizabeth Hospital, and I have some conflict of interest representing some endoscopic company in uniportal and biportal, as well as I practice most of my surgery as a uniportal and biportal surgeries. So there is increased incidence of lumbar fusion due to aging population and familiarity with the techniques, and it has produced good results. So there's increasing a number of patients with degenerative spinal conditions in the United States over the period of time or past 2 decades, an increasing number of fusion, especially in the age group of the 60 to 75 years of age. The 3 essential basic requirements for successful fusion is a good fusion bed preparation, insertion of bone graft or fusion device in the body fusion device, immobilization by stabilization with screws, and correction of the alignment. Overall, minimally invasive has a good outcome and has demonstrated to be as good in the long-term results, with the promise of shorter hospital stay, less pain, as well as less opioid requirement, and possibly less transfusion infection rates. With the evolution of endoscopic spine surgery, is possibly the future of minimally invasive spine surgery. Some of the techniques, such as that of decompression, discectomy, has been gradually been performing more and more by endoscopic spine surgery. So is fusion the next hurdle that we would like to clear? And in terms of the endoscopic spine work group nomenclature, there is a description of the endoscopic techniques. However, there is little discussion on endoscopic fusion. Overall, it is known to be endoscopic assisted fusion. In our literature, we have various approaches for the endoscopic fusion. There's a description of the transcambin approach, which usually use a smaller endoscope, and posterolateral endoscopic fusion, which will be highlighted today. And some surgeons would like to do interlaminar approach as well, with a smaller window and put a smaller cage. And these are the various ways of doing the fusion, between using uniportal or biportal techniques. Overall, there is some good technical consideration. It has a good cosmesis, less blood loss, less infection rate, less perioperative morbidity, with the good aspect of endoscopic fusion. So in terms of uniportal, there are two techniques. One is the transcambin, the other one is posterolateral fusion. I think in the transcambin fusion, we use the Transforminal endoscope, which is 30 degrees. The scope is of a smaller caliber, and the length is longer, while that of the posterolateral fusion is ranges from 10 to 20 degrees, with generally a larger working portal, larger scope, and shorter length of the scope. It has been published on this various description of technique, and you can reference from this review article that we wrote about a couple of years ago. So overall, when it comes to transcambin fusion, we dock on the cambin triangle. We do a foraminoplasty with a special open square cannula. We can introduce the cage after end plate preparation with some of the design curettes. And various types of curettes, as well as special working cannula, is required to protect the exiting and traversing nerve roots before we insert the cage. In the transcambin approach, I think the main risk is to the exiting nerve roots, because the foraminoplasty is limited and traversing nerve root is largely out of the way during the procedure. So the good thing about this K-lift or transcambin fusion is the least invasive of all endoscopic fusion, can be performed under local anesthesia, and is indirect decompression. So also at the same time, in severe stenosis, we need to have an additional scope to do the decompression, and we tend to have to use a smaller footprint cage as a result. And there's some question mark about its risk of subsidence and bone graft requirement. So when it comes to uniportal posterolateral fusion, we have described in a few articles. I think the essential thing is that we will perform a full facet resection for both inferior and superior articular facets, so that we can insert a larger cage. We find that in our article that if we do an outside-in technique from King's point, which is more of the outside part of the facet joint moving to the inside part of the facet joint, then will be a faster technique to perform endoscopic fusion. This technique also allows us to perform interlaminar decompression prior to cage insertion. So the docking point essentially is on the facet joint. We can make two vertical incisions just next to the facet joint, or just next to the pedicle, while the screw is inserted through these two incisions. We tend to make the incision over the on the facet, the upper pedicle of the bilateral side, and then because of mobility of the uniportal endoscope, we can direct the cage insertion through the tube. So this is a video of showing how it's performed. Basically, we dock it on the facet joint directly, and we drill from either from the Wu's point, in this case, inside-out technique, which is essentially a spinal laminar junction, and we drill outwards. And after we completed the facet resection, we can put in the working port directly onto the disc space and perform end plate preparation, trial of cage and cage insertion with a large working tube. And overall, this is the video showing how it's performed. This patient has been reviewed by me for 2 years and has good outcome. Initially has claudication as well as spondylolisthesis of L4-5 with foraminal and extraforaminal stenosis. He has severe back and leg pain, so the decision is to make for endoscopic fusion. We dock at the facet joint on the left side. And we expose the spinal laminar junction, and then we drill the facet joint, inferior articular process, and harvest it for bone graft. And then this is how we harvest the bone graft, and then we perform removal of the ligamentum flavum and superior articular facet resection. And underneath will be that of the traversing nerve root. And then we can remove the superior articular process either by drilling or that of the Chairperson. And then we isolate the disc, perform this preparation, through the uniportal endoscopy. That we need to use the drill most of the time. We use a 3.0 or 3.5 mm diamond burr, and when we reach close to end plate, we use a curved pen field, endoscopic pen field or curved probe, we call it, and perform that of the removal of the disc. Subsequently, we will put in the cage and using various specialized cage glider and protectors. There are some surgeons now may use another portal to insert the cage. I think it's really entirely up to the surgeon. In my earlier series, I do an intraoperative O-arm to check the screw and cage, and they tend to do very well. They ambulate usually the next morning, and then they can go home usually in 1 to 2 days' time. That's the real benefit of endoscopic fusion. And we have published our data. They have achieved good fusion rate with less incidence of subsidence, as well as good ODI and VAS compared to the same group of patients, same group of surgeons in MIS tubular approach. So the uniportal endoscopic fusion maximizes the benefits. It allows harvest of bone graft from facet joints. It allows direct decompression, essentially similar to the technique of MIS T-lift, but we use endoscope, and there is some argument of whether we can visualize better, of course, on the end plate due to the endoscope's nature of visualization inside of the near the end plate. Biportal fusion is very similar in terms of the approach to the disc space. However, we use 2 ports, one for viewing portal and one for working portal. And this is an example. The resection margin is the same from inside out or outside in technique from the spinal laminar junction or superolateral aspect of the facet joint, removing the facet joint completely. And we can initially flex the patient and then extend the patient as we complete the surgery. And that's the docking. The docking is mainly on the pedicles of the upper and lower margin. So we use the same incision to insert cage and subsequently put in the screws. So first we expose the spinal laminar junction, where so-called we have highlighted in one of the articles Wood's point. I think the anatomical landmark should be defined clearly, and also that of the superolateral aspect of the facet joint, which we call Kim's point. So now we drill and mark the area. The good thing about using biportal fusion is that we can actually use chisel like this and perform facetectomy. So we can harvest a big piece of bone for bone graft. And we can insert the potentially larger cages. We have inserted O-leaf and X-leaf cages of the various different company, and they can be inserted through this end plates and intervertebral space. If we use that large of cage, then we tend to use the 45 mm rather than that of the 50 or 55. So we can harvest the whole facet joint of the inferior articular process and then superior articular process like that. We perform bilateral decompression. As you can see, we have went over the top decompression of the contralateral side. In some of the very stiffer spondylolisthesis, I also release the superior articular process from the contralateral side, either by using Keong or using a chisel. So that is how we can perform the bilateral decompression. Now it's ipsilateral side, we remove that of the remnant facet joint, as well as that of the ligamentum flavum to expose both the exiting and traversing nerve roots. If we want to insert a large cage, we tend to be a bit more lateral. But if we want to insert a normal bullet shape interbody cage, then we can be a bit more medial in the dissection or in the putting of the portal. So we expose the disc now, and you can see that it's quite clear definition of the disc. And then we do end plate preparation with the regular shavers. The good thing about biportal fusion, probably there's a less requirement of specialized instruments, endoscopic instrument when we do such cases. So we can use regular shavers as well as that of the curettes. There are some specialized equipment to aid the gliding of the cages into the interbody space. And of course, after we perform the cage, the preparation of the disc space, we evaluate that of the end plates adequately decompressed, end plates adequately prepared, and then we will insert a trowel and bone graft followed by that of the cage. And as you can see from this final trial, before we insert the cage, and then we insert the cage now. The cage this time is a PEEK cage and is assessed with the nerve roots in good shape. And we put in the percutaneous pedicle screw. We can also put in the screw under endoscopic visualization of the ipsilateral side. Some go to extent of doing bilateral endoscopic guided screw. I personally like to do that with either the OR model, fluoroscopy to do the percutaneous pedicle screw insertion, or put cage before screw, and this is the final outcome of the image, and the patient have good fusion. We can do that for grade 2 slip as well, just to highlight and quickly go through, and very similar in terms of cage positioning and reduction. We can reduce the grade 2 slip quite well, and they are able to stand usually 6 hours after surgery, and this is the how it looks like after we put in the cage. So sometimes we encounter deformity. We have published in our series that we do using multiple level fusion can correct 10 to 40 degree minor curve, and we can do a multi-level fusion as well, like in this case, to correct some deformity and still maintaining good lordosis. And sometimes we can use that as a part of addition of fusion, supplementary fusion after we do multiple lateral fusion for L5S1 and L12. In this case, patient with kyphosis, scoliosis, degenerative scoliosis, multi-level. This is found in L1 to L5, and multiple level of severe spinal stenosis, severe to moderate spinal stenosis is found. A patient have claudication and severe back pain. So we perform 3-level lateral access fusion, which we have been discussed in the previous session. And then on the L12, we did endoscopic fusion. So I think in L12, when we do lateral access fusion, can be challenging due to the rib, be it for X or O lift. I've tried in various manner. There is some difficulty, although we can circumvent with using of the by doing angulated cork. But in this case, since he has severe stenosis, he require to a 3-level decompression. So I did the 3-level endoscopic decompression and then added the endoscopic fusion in the L12. So this is the wound. Interestingly, he doesn't need any blood transfusion, and really amazingly, it's angulated, but he walked on post-op day 1. And he's very comfortable. It's really amazing, but of course, I'm not saying every single one with 4-level fusion walks the next day. He's a stoic man and he's managed to do it. So overall, there's some limitation in endoscopic fusion. I think overall, similar limitation to that of MIS fusion. I do that up to 3 levels. I think for 4 levels is possible. My mentor sitting here, Professor Hyeun Kim, have done it up to 4 level of fusion, 5 level of fusion. But to my stamina, I do up to 3 levels. If I need more than 3 level, I tend to do a few of them with the lateral position. I think if a grade 3 or 4 translational deformity, there is consideration of bilateral fusion. That's one technique, or we can do it open. So it's really up to the individual's surgeon's comfort level of endoscopic fusion. In this case, a 21-year-old bilateral severe spondylolisthesis of grade 3 with the dome-shaped sacrum and end plate spur. I opted to do it open with supplementation of the screw, and fuse the level by doing translation of screws as well. And overall, there are meta-analysis showing various clinical results. And then it shows that overall transcambient and posterolateral approach have favorable outcome with good clinical outcome. Complications are minor, and there's improvement in back pain and leg pain. Overall, for fusion, I think it is really at the quaternary level when we are really comfortable with endoscopy. Then we'll be challenging ourselves with various types of fusion. But overall, with its significant benefit, it is something that we can consider. We evaluate our outcome and understand the differences in handling and the learning curve, and cater our needs to whether we do uniportal or biportal fusion. I think both have good outcomes.
So thank you for your talk, Dr. Wu. There's a question in chat by Professor Kwan. He wants to know, do you use any bone graft or BMP to enhance fusion?
I use the autograph from the facet harvest. There are surgeons that use iliac crest bone graft. They make a separate incision, and especially in K-leaf, the transcambium fusion, they do that to harvest the iliac crest. And I use BMP. I use 1 mg per level. But I'm aware that there are people who just have additional allograft rather than just using BMP, and I think they are similar. I think in terms of endoscopic fusion, in terms of bone graft usage, it's very similar to MIST leaf. So I think it's really up to the surgeon's comfort level.
There's also another question to all the panelists, all the speakers. How do we manage a dural tear in endoscopic spine surgery?
In Uniportal, I tend to be quite small, so we use gel foam tackle seal technique. We published that before. And I think Professor Hao Dong also published about using the anastomo clip. And we have specially designed instruments in Biportal. We can actually suture them up to the specialized instrument is just a knot pusher, so that we can stitch them up. I think either way we can do primary repair or using tackle seal gel foam technique to repair the dural tear. If the dural tear is more than 1 cm, I think sometimes we can open and repair them as well. It's up to the assessment of the surgeon.
For the Uniportal, I think if the dural tear is small, less than 4 millimeter, I will cover the dural tear by the gelatin sponge. If more than 4 millimeter, I will do the dural tear under the endoscopy. Can I share my screen?
Okay.
I will show you. You can see my. This is
yeah.
How to I repair my the dural damage. In this case, I use the special needle holder to repair the dural tear directly, and use a pusher to make the node. So I think is easily the procedure for the UBE. And this is a needle holder.
So, do you think they are more forgiving in endoscopic spine surgery when compared to open dural tests, or is it the same? Like, what about the outcomes?
I feel that smaller dural tears where there is intact arachnoid membrane and there is no nerve root herniation, they can definitely be conserved well, because as you see in the open surgery, there is no cutting of the muscles, so there is only dilatation of the muscle fibers. And what happens with that is once the taco seal or whatever it is, you just keep it, or even a gel foam, you keep it on the tear and you remove the dilator and the working channel. All the crisscross muscle fibers, they come in place and they act like an internal bandage to prevent further leakage of the tear. So it's much more forgiving with full endoscopic surgery as compared to open surgery. We immediately mobilize the patient in the same evening also, or even the next day. So there's no bed rest or anything like that.
And also endoscopic spinal surgery, the dural tear happens so many cases, but fortunately on endoscopic spine procedure is a very small working space. Because of that, only some preventing the herniation of the nerve root is sufficient, like some taco. In Korea, mostly is endoscopic spine surgeon use the taco shield patch. That is sufficient in spite of the large dural tear.
Professor Wu, Professor Wu, I have a question for you. Okay, and my question is for Professor Wu and also for Hyeun Kim. Both of you do endoscopy fusion. It is more popular now. My question is, which kind of cage is the more popular, is more promising in the future for endoscopic fusion? Which kind of cage is more promising, more better? Kim and Professor Wu.
I think 3D printed titanium cage is good. I was largely influenced by Prof Kim. It does show a very good series, and I use them myself. I find it quite good. There are some larger cages of X and O lift that has 3D printed, but largely now the market is still peak cages, and I still use them for larger footprint. As I move to private practice, we try to keep the procedure maybe a little bit more straightforward and safe. So I tend to use the 3D printed cages that can rotate and create a good lordosis. And I think that's sufficient for fusion. In some of the patients, older ones, where the end plate may be a bit more, they are more worried about subsidence, then I use a larger footprint cages. Prof Kim, maybe you can highlight more.
Professor Kim, what's your opinion?
Yeah, maybe in the next generation, the two topics will be very important in the endoscopic lumbar interoral fusion, such as first is a 3D printed cage, second is a BMP. Maybe nowadays so many companies they already searching already starting the some use of the BMP in the endoscopic cage, and also so many companies already make a 3D printed. The important action in the future of the endoscopic lumbar interoral fusion.
So large size cage is more better, I think. So expandable cage or large size cage, which is better for endoscopic fusion?
Yes, there is a good comment. Maybe in the future, some larger cage like a 2 kg or some bigger cage, some expandable cage will be useful. But we should think about it, some expansion of the cranial to caudal or transverse. Because of that, maybe like before cases of some to make bony breakage. But if we need some more actual wide expansion of the cage will be useful in the future.
I have some. We need to be very careful with expandable cage. I think if we want to use expandable cage, it should be those graduated expansion rather than all or none. That means some expandable cage really need to expand fully. Otherwise, they can't expand halfway, and it really forces the cage into the end plate. It can risk subsidence in osteoporotic patients. So we need to be more cautious. I think those that expand both in terms of height and laterally may be more gradual. I think a better design must be there. Otherwise, before that happen, I tend to use more of those static cages. I think those are proven and well trialed. There is a question, two questions, one from Chikit, one from Prof Kwan. One is first, I think the Prof Kwan one probably related to fusion. We will answer that first. That one is on how do we create lordosis on multiple level endo-T lift. We asked Prof Kim about that. Then the second question is for all of us, whether to do biportal or uniportal or learn both. I think that is a very controversial question. Maybe Prof Kim can answer how about how you create lordosis in multiple level endo-T lift.
Actually, endoscopic lumbar interval fusion is really benefit of the chronic adhesive disc drilling. We already know that with some cutting the chronic adhesive disc drilling, it makes some disc heights maybe so expanded so highly. Because of that, we can insert larger cage and angled cages possible. And currently, I use the 13 and 14 and 15 millimeter cage, and sometimes insert the 12 and 16 degree angled cages insertion is possible endoscopic lumbar interval fusion. Because of that, making lordosis is not difficult in the endoscopic lumbar interval fusion.
Okay. I agree, and I think a lot of times we need to really bend the rod, and the rod dictates a lot of the lordosis. So there isn't a lot of problem in creating lordosis. I think it's quite similar to MIST lift in terms of creating lordosis. For Dr. Chiki's question to Dr. Zhang and me, I think maybe Dr. Zhang can answer this first. If the surgeon is keen to take up endoscopic surgery, does he or she need to learn all approaches of both uniportal or biportal, or just either one is enough? Maybe Prof Kim and maybe Pramod and Prof Kim can answer with Zhang Wei. I'm sitting on the fence, that's why I do both.
Sorry, which question?
Yeah, so are you able to solve all surgery, and would you encourage people to learn uniportal or biportal? Maybe Prof Zhang Wei, Prof Kim, and Pramod answer this. Since I'm sitting on the fence, I do both type of surgery.
Yeah, speaking.
Okay, Pramod first, maybe. Yes.
Yeah, should I talk or?
Yeah, okay. Then after that, Prof Zhang, yes. Okay.
Okay. So actually, even I do both the techniques, biportal and full endoscopy. But if you compare, I think the variety which is offered with full endoscopy is much more on the minimally invasive pattern, especially if you consider it in the thoracic spine, the transforminal approaches, transthoracic approaches. Those are quite well possible with full endoscopy. The only issue with full endoscopy, why this argument has started whether full endoscopy or biportal, I think is the price factor. We need specialized equipments for uniportal endoscopies, which are quite expensive in the initial phase. But once you invest in those particular things, then the whole thing becomes very easy. Whereas in biportal, I think you're already using what is mostly available in the operation theaters, like most of the equipments which are used by the shoulder surgeons or the arthroscopy surgeons, they can be used in biportal. So this is my way of looking at it. But again, I would say that learning both the techniques gives every surgeon a different perspective, and everybody has a different way or different talent. And maybe a person who is doing both the surgeries, one might be more comfortable with biportal endoscopy, but learning both the approaches, I would suggest is, you can start with biportal and then migrate to uniportal, or you can do either way.
In my opinion, in my center, I only do the biportal. So there is cervical case or thoracic case, and the lumbar case, I do the majority of time the case by the biportal. I think biportal is have many the approaches. I think the paraspinal approach of biportal is learned from the uniportal. Is another approach is the contralateral approach is also similar to the sublaminar or translaminar approach. So the advantage of the uniportal is in the cervical level, especially cervical disc herniation, the center disc herniation. I think it's a challenging case for the biportal, but the paraspinal approach can be solve this problem. Maybe P plus 5 centimeter we can get to the central area of thoracic. And the high level of the lumbar disc herniation is easier for the uniportal. But for the central disc herniation or the disc herniation or the high level lumbar disc herniation, I also choose the paraspinal approach of Biportal. This is my opinion.
Okay, I think it's maybe just 1 minute, Prof. Kim, to summarize, then we move on. We are behind time. Prof. Kim, any comment?
Dr. Wu, my connection is not so good. Please, maybe in my opinion, but the endoscopic spine surgery of uniportal and biportal is there, and this always keep in mind is the rationale of the endoscopic spine surgery, and sometimes maybe some doctors can possibly use the biportal spine surgery, but some doctors can possibly uniportal spine surgery. But anyway, it always keep in mind who can give the more good result to the patient. But if we possible, we can give the some uniportal endoscopic spine surgery. That will be the best option. But in some of cases, that is not difficult because of that. To learn the uniportal and biportal will be served to more good to clinical result to the patient.
Okay. I think I will introduce Yudha, and then Loya will introduce Prof. Shi.
Yeah.
Okay, so Dr. Yudha will be discussing a case on awake transforminal lumbar discectomy in degenerative disc herniation with coronal deformity. He's a doctor of medicine and health sciences, faculty of medicine, public health and nursing in Gajah Mada University, Yogyakarta. Prof. Yudha, take it away.
Thank you very much, Professor Penghu. Again, I would like to congratulate Professor Kwan and thank you very much for the honor to be able to share our cases. It's a great honor to be able to share with all of the teachers here. Again, I hope, can you hear my voice clearly, Dr. Peng?
Speak a bit louder, maybe.
Yeah, okay, apologize. So this is my presentation. Hopefully it will not take very long. This is especially for us, the young surgeon that trying to embark the venture of doing endoscopy for spine degenerative cases. This case is, first of all, this case is a female, 64 years old. Patient has a difficulty in walking since 1 year before admission. And then if we see here, the patients need at least 2 persons to help to walk. And then most of one within 6 months, 1 year, bound to wheelchair and increasing numbness. So that the patient now and the family is planning to do surgery. However, because of multiple comorbidities, the patient refused to do big surgeries and instrumentation because of the condition. The pre-operative VAS is about 5 to 6 because the patient is in pain medication. So before we go forward, I'd like to also emphasize that there are accompanying deformity in these patients even since the physical examination. So that is also one of the things that we need to tackle in treating this kind of cases. So this is the patient's MRI from sagittal and axial. We can see also from the MRI myelographic view, we can also see there are multiple stenosis in which the compression is mainly on L2 to S1, in which the most severe is L3-4 and L4-5, in which also correlated with sagittal and coronal problem of deformity. In here, we always measure the pre-operative X-ray with the sacropelvic alignment to see that there are how much the problem related with the deformity of this patient. So this patient have a decrease of lumbar lordosis with the PI-LL mismatch more than 10 or 15 degrees. So the problem is not only the compression, but there are also degenerative and then deformity problem. So this is the closer view of the axial and sagittal view. We can see that multiple compression here, but mainly on L34 and L45 that relates with the main compression. Again, we have to be able to delineate in which level that we will plan to do the compression. Again, because we are not going to do massive reconstruction in these patients. From the physical examination, from the physical examinations, we see here L3 to S1 all decrease for the sensory, and then the motoric is roughly about 3 to 2, and S1 is 1. So there are motoric deficit definitely occurred in this patient. So what we did is, I think all of the speakers have already explained that doing it endoscopic way for this kind of cases is something that can be considered for this kind of patients with several comorbidities, in which we can go in and go out more or less not as aggressive with the same amount of objective. What I'd like to emphasize here is that first, there are only several steps that we need to do, in which first the docking. Really, for interlaminar, is really less invasive with the C-arm, and then doing a valvectomy. In here, we only use a Kerrison punch, in which sometimes burr are not available. So it's possible if you only have a Kerrison punch, although it will take quite a challenge in doing the compression. After the valvectomy, and then you can proceed with facetectomy that really impinge the nerve root of the exiting part, and then we do contralaterally to go the contralateral side, and then also the final evaluation after doing the decompression. Again, okay, and then for the L34, we go after the L45. Again, doing the docking posteriorly, less C-arm is needed, and then do a facetectomy, and then do a contralateral valvectomy, already mentioned from the previous speaker. And then what's good is we can also see the final evaluation regarding how much you can free them. What I'd like to see here is already free from the left side and the right side, from the ipsilateral and contralateral with uniportal technique, again with the consideration of the patient's comorbidity and your aggressiveness in doing decompression. Okay, so to see the result directly after the surgery, we can see the patient's still difficult, this directly for surgery, but in time, the patient is getting more and more independent. I know it's still a lot of work regarding the patient's strength and motor power, but we are seeing a good result, and it is also shown by the sagittal and coronal parameter of the X-ray here, showing that the patient's deformity, the indirect deformity due to compensatory problem of the pathological part, if you decompress it well enough, more or less the parameter of the radiological will improve, in which shown in this patient, the number lordosis is increased, and then LL-PI mismatch is also improved, therefore making a better result for the patient's outcome. Okay, so here we can also see the previous malalignment clinically is improved after you do a well decompression, depend on the etiology of the compression. So you have to tackle them based on the location of the compression. So this is the physical examination showing there are improvements, in which this technique is something that I think we need to consider ourselves to be able to do as a spine surgeon. I think that's all. This is just a quick remark in which, if you'd like to choose whether interlaminar technique or transforminal technique, again, there are considerations that need to apologize to consider regarding the anesthesia, the versatility, and then where to do the decompression. And again, CR shot is something that we need to really think of, and which is really minimized in interlaminar technique. Thank you very much, Dr. Peng Hak.
Thank you, Yudha. Very interesting case. Maybe we can discuss. How many of us actually found that after decompression, we actually have improved in the scoliosis and lordosis? It's a very interesting discussion.
Yeah, Dr. Peng Hang, thank you. So one of the, I think a lot of paper already mentioned that PILL mismatch is something that's really need to be taken care of with regard to patient activity following the surgery. So what I would like to emphasize that we always measure, and there are sagittal differences following proper decompression. So it will go linear with the patient's improvement after you do the endoscopic surgery. I think that is one of the things that we need to evaluate after the decompression, not just seeing the structural decompression, but functional wise, with the X-ray following the decompression, you can directly see the improvement. So we are more or less treating the deformity indirectly. I think that's as an endoscopic surgeon, I think we must also appreciate that.
Any other opinions? I think Dr. Yudha, if you can share your screen, like the X-rays and MRI, so that we can take opinion of other panelists, that whether do they want to tackle it the same way or a different way. Yeah, pre-op, just a slide before, yeah. Yeah, I think that should be enough. So Dr. Kim, how would you, what would be your plan in this case?
Actually, I'm also in this, like this case is firstly we tried endoscopic decompression because of that the degenerative deformity not disturb the patient symptom. Mostly symptom is some related to the spinal stenosis, maybe because of the, and also after decompression of the nerve, maybe it makes some improvement of the deformity can possible, like Yudha's cases. Because of that, I tried the decompression first, endoscopic decompression first.
Okay.
Yeah, Vijay, actually, this is quite a challenge because we already see from the X-ray, we see the black disc showing some might argue due to instability and 3-4-2-3. However, during flexion extension is more or less stable. So from the classification of the stability, so therefore we go with the decompression only. But however, maybe there are inputs from other speakers maybe for this case.
Dr. Wu, would you like to add any fusion? Just to keep the discussion alive, would you like to fuse any of the segments, or would you like to do decompression alone, if this was your case?
If the patient has minimal back pain, and from what I can see, she has really a lot of stenosis symptom, weakness and numbness, not so much back pain. We must, after I do endoscopy, I move away from looking at vacuum discs and thinking that all of them should be fused. I really look at the patient. If the patient's back pain is severe and then she can't get out of bed, when she turns there's pain, then I would try to fuse them. And in fusion, in a very unfit patient like this, we may consider doing LA sedation, K-lifts, and then another day come and do this, what Dr. Yudha did to decompress the patient. I think that is one option for very unfit patient, because if you want to fuse 3 or 4 level fusion, maybe a few people like Prof Kim who do it very, very fast, or Prof Zhang Wei, you know. So even I do 3-level biportal fusion, it would still take a few hours. So maybe I have to do 2 op. But if I were to do a 3-level fusion, then I would do biportal. I think it's faster. I think Prof Kim can do it very, very fast with uniportal and decompress at the same time. But for me, if I have to fuse so many levels and I have to decompress them, I would do it biportal.
I think for the two-level multi-level fusion, we can use the small size cage. It can reduce the time of the fusion time.
Yeah.
If no further questions, we can move to the next case. Next case is to be presented by Dr. Bing, Dr. Xu Wei Bing from China.
Okay.
Yes.
Thank you.
Yes.
I'm Xu Wei Bing from China. Thank you for invitation. Dr. Wu invite me. My team member Dongfang Yang read PPT for me. Dongfang.
Okay, good afternoon, everyone. Can I share my screen? Okay. Can you hear me?
Yes. Yes.
Okay. Sorry, there's something wrong with my camera. Good afternoon, everyone. I'm honored to be here today to learn and share some knowledge on spinal endoscopy with all of you guys. My name is Dongfang Yang. I'm representing Dr. Xu to deliver his presentation today. It's a case report and discussion. Our case is a 42-year-old male with symptom of right side radiating pain in the lower extremity for 15 years. The physical examination includes angle dorsiflexion strength grade 4 and angle plantar flexion strength grade 4, and helix dorsiflexion strength grade 4, and the hypoesthesia in the lateral leg, dorsal feet, and the lateral foot margin, and with dismissed Achilles reflex. So the preoperative X-ray shows no instability, and the preoperative CT scan shows the foraminal stenosis and the lateral recess stenosis on the right side at both L4-5 and L5-S1. And the compress caused by the boning, the hypertrophy, and or calcified some bony structure. And the MRI also show the same pathology. So what's the surgical plan? We have some choice. First, P-leaf or the MIST leaf. If we choose a MIST compression, then which approach will you take? The uniportal, a biportal, or MED? That's Dr. Xu, the Professor Xu's question. Shall we get a?
Yeah, so maybe we can have a panel discussion, just a short one. So maybe we start with Dr. Pramod. Dr. Pramod, what will you use, since you mentioned you also do both biportal and uniportal? Pramod not around, maybe Prof Kim and then Prof Shi.
Dongfang, go back your slide to CT scan.
Yeah.
CT. Okay.
So Prof Kim, this is quite interesting. I would like to ask you now, because you do both paraspinal now and also ICELF contralateral approach, right? So now in this type of case, will you do contralateral approach or you do paraspinal approach now?
Actually, this case is main problem is some weakness due to the calcified problem of the disc and osteophytic bone. Because of that, some safely management of this this point is very important. Because of that, I will do the endoscope decompression with the large scope and small scope together. Maybe, but some from the contractor side is sometimes some danger to the some traction of the nerve of the contractor side. Because of that, I will try the ipsilateral side. And also if they needed the foraminal decompression, maybe some endoscope fusion, also some another option. And also before cases of Yudha cases, also if the patient have so severe back pain, they need some endoscope fusion. And this case also similar cases, some similar situation.
Yeah, I find that using I think ipsilateral side is easier for calcified disc. Calcified disc, in my opinion, tends to also be quite central, and then the PLL also tends to be calcified. So sometimes need to deal with it ipsilaterally so that we can gently mobilize the nerve before we gradually remove the calcified disc. It's very challenging to do it contralaterally, to retract the nerve and then to attack the PLL, which is kind of calcified as well. So yeah, it really difficult. Then sometimes maybe like Prof Kim say, endoscopic fusion when you have a larger area of resection of bone may be helpful. Really depend on patient's symptom.
Maybe if this patient, the main problem of nerve damage to the calcified disc, maybe first try the transforminal approach, also some another option.
Yeah, I have an opinion here. Like this is one of the difficult cases for even an expert. Like I would suggest that you have to be very generous with your bone resection, even the facet joint resection in such cases. Doing a contralateral approach is absolutely no for this case. For me, I would do a bilateral ipsilateral approach, doing it well, get adequate space laterally so that I'll be able to look under the nerve root and shave off all the sharp projections of the calcified part. If it is a blind, my job is not to resect the whole calcified disc herniation, just to make it smooth and rounded enough so that it doesn't irritate the undersurface of the dura and the nerve root. Whereas the endoscope has to sit on the surface. It has to be a completely outside out kind of technique where you should not go inside and manipulate inside the spinal canal. Just stay on the surface over the ligamentum flavum, do adequate generous bone drilling on either side, remove the flavum from the top without entering much of an instrument inside. That would be my approach for such cases. And as Dr. Kim told that yes, there is foraminal stenosis also here in this patient, that in such cases I would do a separate transforaminal foraminoplastic approach, which is again going to be an extra foraminal kind of thing, not anchoring the endoscope inside the disc, but just so placing it over the surface of the undersurface of the facet joint or the pedicle, and then working from that area, always on the top of the exiting nerve root, not retracting the nerve root in any way. Yeah.
Yeah, I have when I was doing when I do Uniportal also, I often mix transforminal and interlaminar, especially I think in some of the L3-4 cases, but of course it's L4-5-1 difficult cases as well. When it's calcified, then decompress interlaminar first, then I go to transforminal to take out the calcified disc in the center component, all on the same side. Let's say it's on this case right side, then I will be right side doing both. Done a few cases. I don't think they get unstable. I think instability not so much of a problem in those cases they have done. You can do two approaches in the same patient. Try not to touch the nerve root. I think it's possible too. I think there's just one comment. I think one being doing Uniportal and one this distinct advantage is sometimes you can just do multiple small op. You know, you do a lateral like Pramod say you can do a left side interlaminar lateral recess decompression, then you do a transforminal, and then you go to the right side and then do a lateral recess decompression, or using one little bit of small incision here and there. That's one advantage of uniportal over biportal sometimes. If we do that biportal, then we'll be making like 6 incision in the patient. Yeah. I mean, if that is an advantage overall.
Well
Dr.
said.
Ramdev wants to know, is there any role of endoscopic burring of the osteophyte?
Yeah, there is definitely a role of endoscopic burring, but there are 2 types of burrs available. One is the mechanical electric burr, which is we are using the high-speed burr, and the second one is a face mill, which is actually a hand-driven burr. So it's like a smooth cylinder with a sharp serrated edge on the top. So whenever we are dealing with osteophytes which are lying under the surface of the nerve root, this is what we use. We use the hand burr or the hand driven burr or the face mill, which will just smoothen the surface of the osteophyte and take away the sharpness of the irritation of the nerve root. It's very dangerous to use a high speed electrical burr near the nerve root, so close to the nerve root, because sometimes it may be difficult to control, and this little bit of slippage will just cause a disaster in that particular area.
Maybe just to give a comment, I agree with Dr. Pramod. Response in doing is really really risky to put a high-speed burr there. But maybe if we see the gap from the MRI, you can see a soft tissue gap between the end plate. So usually you can really go in between, and then you can put a small caisson, for example, 2, and then you can work your way lateral and medial slowly, but without using burr. But however, you have to be sure that you are really free of the dural or tectal sacs with regards to anterior part. So you can really remove, release that. Maybe you can go in between the soft spot between 2 of the end plate, and you can work your way to decompress based on that. But however, I agree with the generous bony work in this kind of cases.
So, with the constraints of time, I think we can move ahead, see what was done.
Okay, thank you to all the professors for your enlightening discussion. So here's our strategy. We performed the traditional contralateral decompression. First, we treat this case by the UBE. At L405 segment, we perform the traditional contralateral decompression on the left side, and for the L5S1, we perform the CIA, the contralateral inclinatory approach, also on the left side. The traditional contralateral approach is we are all familiar with this approach. His indication generally includes lateral recess stenosis combined with, especially combined with foraminal stenosis. And the contralateral inclinatory approach, where surgeons stand on the healthy side. In this case, we stand on the left side and perform contralateral decompression through 2 incisions made on the affected side. The CIA is similar to the cervical inclinatory approach proposed by the Chen 2011. The CIA is first we should introduce the L4-5 segment. We use burr and curate to enlarge the lateral recess. Here's a transversing route. Then we use the crescent punch to remove the hypertrophied ligamentum flavor covering the foramen to release the exiting root. The advantage of the CLA is that we can decompress both exiting root and transversing root simultaneously, and also we can preserve the facet joint as much as possible. So then we perform the CIA at L5S1. Firstly, we remove the calcified tissue with burr and then remove the softer tissue beneath it. Then we also decompress the lateral recess and the foramen area like CLA. The CLA make it easier to address the disc herniation on the ventral side of the contralateral dual sac. Even the instrument angle may be higher, maybe bigger. It's also easy to perform the contralateral decompression of the transversing root or the exiting root like CLA. Yeah, here's the exiting root. Well, here are the post-operative CT scans. We can see the difference between CLA and CIA clearly. Well, here, what's a key point to help us make our final surgical decision? First, important one is whether we can get a full decompression, and with UB, yes, we can get the full decompression. And then the surgical trauma is small, and the operating time is about 2 hours, similar to the open surgery. Finally, we can achieve a full decompression without a fusion. We think that's definitely good to a patient. So when we talk about the CIA, what's the indication? We think unilateral pathology, in this case, the right side, and especially with the right side disc problem, especially the ventral side, need to deal with, because for most surgeons with right hand, we stand at the left side and holding a burr or other instrument in the right hand, facilitated dealing with the inferior edge of the right lamina, while minimizing damage to the multifidus. Compared to the CLA, it's easier to address the ventral side of the right intervertebral disc with less irritation to the nerve. Here's the incision location. We made the cranial skin incision was made at the level of the lower third of the upper lamina. The caudal skin incision was made at the level of the upper third of the pedicle and of the disc vertebrae. Both decisions were made obliquely along the multifidus. This one is important, which I will translate, or I will translate in detail. The distance between two incisions was about 2 or 3 millimeters. And for traditional CLA incision location, we should reference lines for this. We should consider the inlets. The lamina margin around the interlaminar space, the right side outside the inlet should be lower than the left side. This for right-hander. We make a skin incision for the inlet just lateral to a spinous process for only ipsilateral approach, 5 millimeter apart a lateral side on the left side. And 10 millimeter apart lateral side on the right side approach for perform the contralateral approach. So in conclusion, we first when we perform the UBCLA, we think the indication maybe includes the lateral recess stenosis, especially combined with foraminal stenosis. We can decompress the exiting root or transversing root simultaneously and preserve the facet joint. And for CIA, we especially for the unilateral pathology, and we also can decompress both nerve roots, and we can also deal with the contralateral ventral disc tissue. However, the CIA is limited for foraminal stenosis in some degrees. For example, if the X foraminal herniation, maybe we cannot reach so far like the contralateral approach. So the third, finally, is we think the UBBS allows us can do more lumbar degenerative disease to be treated with a minimally invasive procedures, less fusion surgery, more mystic compression, and if the fusion surgery is inevitable and less fusion segment. But also we have some limitation associated with CIA. First is the spinous process deviation toward to the pathology side. The spinous process hypertrophy or the central or the extraforaminal disc herniation. I said it before. They make the CIA may not can reach so far like the CLA. And the second one is the learning curve may be maybe higher. And the third one is the skin incision are suggested to be made obliquely along the multifidus, being about 5 millimeter lateral to the spinal process, and looking at the spinal lamina joint. Don't to put this lateral too lateral, or it's easy to drill out the contralateral side of the lamina because of its inclinatory trajectory. So maybe leading the violation of the facet joint and the joint capsule. Okay, thank you for your time.
Thank you for your very interesting presentation.
I think it's very interesting, Prof. Xu. I want to tap your brain. Why not both do a contralateral approach? Why contralateral inclinatory approach for the L5S1, right, I believe? In your contralateral inclinatory approach, because you use a 30-degree scope, you look very much like a contralateral approach, actually. Maybe you can comment why for your why CIA, why contralateral inclinatory approach for the is it L5S1 or L45 that you use the inclinatory approach?
L5S1, we perform the CIA. I guess I asked the same question to Dr. Xu. He said he considering the ventral part, this calcified or the bony hypertrophy, it's not easy to deal with from the contralateral CLA.
Okay. Yeah, and you can see from here the spinous process kind of tilted towards the right side. So your CIA might have some pushing to the push you more laterally and violate the facet joint. How do you prevent that?
You mean isthmus fracture?
You can, because if you use CIA, we influenced by the spinous process. Our scope will tend to have to push the. We are acting against the spinous process if we do CIA. So how and in this patient, the spinous process is tilted towards the right. So how do you prevent getting isthmus fracture, yes, and facet injury?
So the portal location is a 5 millimeter lateral spread process. It is key. So Dr. Yang had said the location of portal not lateral too much from spread process. And we use 30-degree arthroscope. It is under curved patient to decompression former stenosis. So it can reduce isthmus fracture.
Then why not on the right side? Just do a right side standing UBE.
Because in this case, we can see the L4, L5, and S1, the 3 nerve root get involved. So not just to deal with calcified tissue, but also we should perform the foraminal decompression and the lateral decompression at both segments. Not at L4-5 or at F5-S1, we both segments we should perform the lateral recess decompression and the foraminal decompression simultaneously. So if we use the lateral decompression like traditional, we perform like that, but we cannot. It's not very easy for us to deal with the foraminal decompression.
So if no further questions, I think we can call it a day for today.
Thank you, everyone. I think it's been a wonderful session. I think Prof. Xu have shown a very advanced epitomized biportal technique, and Prof. Kim, Prof. Pramod, and Prof. Zhang Wei also, and Yudha show very difficult cases and very well elaborated. The illustration has been good, and the description of technique has been good. Actually, when we started, Loya and I started this workshop, we wanted to be not so advanced, but I think with all these experts, it kind of pushes the boundary even more advanced than I thought. But yeah, thank you very much for everyone.
Thank you, Dr. Wu and Dr. Vijay. I think Dr. Wu Pang has actually summarized the whole session. The session has been very popular. We had about 722 views on the OrthoTV. And on behalf of APSS, I would like to thank all the speakers, the case presenters, and the chairpersons for taking their time on a Sunday to be with us. My sincere thanks to the president of APSS, Professor Dato Kwan, and the secretariat, Kaylin and Jennifer, and for the OrthoTV for the event. And I would like to remind all the viewers and the faculty to save the date. The APSS 7th annual meeting will be held in Hong Kong on the 14th and 14th to 16th of June on 2024. Further mails will be sent to everybody. And I hope to see you all in the annual meeting. Thank you all. Bye.
Thank you.
Thank you. Thank you.
Thank you. Bye. Have a
Bye.
good Sunday.
Thank you.
Goodbye.
Goodbye.